Morning, everyone. It's been a couple of years since I've been at this conference. I've been to the What's New in Medicine conference a couple of times now, and just let me start by saying it is so great to see faces again and not talk into these blank Zoom screens with a bunch of blacked out screens and just names. It's just so nice to see you all again. I'm here to give a talk on diabetes management. You've just seen a talk on how to cure diabetes. So this is odd. There are some who say that type 2 diabetes is a surgical disease in the year 2022, and I can't argue with them. Back in the 1960s, there were many that said that peptic ulcer disease was a surgical disease. Back in the 1960s, if you would have gone to a medical conference, you might have seen a talk on the cure of peptic ulcer disease with surgery. And then you might have afterwards seen a talk on treating peptic ulcer disease with antibiotics and acid blockers. I wonder if 40 years from now, if we will look at diabetes in the same way that we look at peptic ulcer disease in retrospect. There are some who say that we are in a golden age now of diabetes treatment where decades of advances in basic science have now produced a whole slew of new treatments that improve diabetes care. The upshot is that it raises the complexity for you, the advice giver, and I'm here to help you wade through that. So I appreciate your attention. What we're going to do today is we're going to talk about some cardiovascular outcomes trials for patients with type 2 diabetes. We're going to weigh the risks and benefits of multiple different classes of medications for the management of type 2 diabetes. And that is going to require me to compare multiple branded meds head to head. We're going to consider the cost and potential value added of continuous glucose monitor systems that there's no generic CGM. So this is actually the most important slide of the talk. I'm not here to sell you anything. I don't take any money from industry. I don't have any relationships with industry whatsoever. I'm going to try to be pointed in my criticism and critique of meds and systems where I can. Am I not picking up? Okay, thanks. I can speak closer too. Is this any better? This one? Okay, thank you. All right. So let's start off with a brief timeline. I'm going to assemble kind of a complicated slide here. Hopefully you can see a timeline on the bottom of the screen that summarizes the last 150 or so years of diabetes management. Even since antiquity, since the ancient Egyptian and ancient Indian times, there have been doctors then that noticed that certain patients had urine that attracted flies and ants. And when those doctors tasted the urine, it tasted like honey. That's how diabetes mellitus got its name, honey diabetes. And for thousands of years, it was thought that this was a disease where the body wasted sugar out in the urine. And the treatment for diabetes all that time was to try to replace the sugar that was being lost by giving a high sugar diet. Didn't go so well. But that was the state of the art for diabetes treatment for thousands of years, all the way up until the year 1870, when in the Franco-Prussian War, the Prussian army laid siege to Paris. And there was an astute doctor, Apollinaire Boucherat, on the diabetes ward during the siege of Paris, and he noticed that patients on the diabetes ward seemed to live a few days longer on their war rations than when they were being given their typical high-carb, high-sugar diet. And took notice of this and said, well, what if we're doing this all wrong? What if we should just put people on a low-carb diet instead? And he was really onto something. Like many French inventions that got Americanized, Frederick Allen and E.P. Joslin kind of refined the low-carb diet into what got termed starvation therapy. And this was the state of the art in diabetes management from the 1880s all the way up to the early 1900s. And that's where these historical photos came in. You had a little boy who was getting starvation therapy. That's his mom there. And I always found that picture of the mom just haunting, just the way that she's sort of looking at the camera, almost like with like anger and disdain. But then 101 years ago, in 1921, Frederick Banting and Charles Best at University of Toronto figured out how to purify and pharmaceuticalize insulin as a treatment. And here the good news is that's the same kid 90 days later after insulin therapy. So back in those days, it took 2,000 pounds of pig pancreas to make 8 ounces of insulin. And that was the state of the art all the way up through the 1980s, when using recombinant DNA technology, now we took the insulin gene and put it into a yeast and could brew it up in big factories and make recombinant insulin. In the 90s, we saw the bioengineered insulins, the insulins that could be engineered to last longer, like insulin glargine, or be really fast-acting, like Aspart or Lispro or glulisine. We have inhaled insulins now, Afrezza. And we also have biosimilar, we have the biosimilar insulins. Now that these are off patent, we actually have other insulins that can be used as well. Starting in the 1960s, we had pill medications for diabetes, the sulfonylureas. In the early 1990s, metformin came on the scene. A few years later, we had medicines that inhibit the digestion of sugars, the alpha-glucosidase inhibitors, acarbose and miglatol. In the mid-90s, we got insulin sensitizers, the PPAR gamma agonists. The timeline's getting kind of full here. In the late 90s and early 2000s, we had the injectable incretin agents, the GLP-1 agonists. We've got a new member now that I will talk about. In the early 2000s, we had meds that inhibited DPP-4. Then we have the meds that block SGLT2. These are the newest, some of the newest class of meds, the meds that make people pee out sugar. And then we got a couple at the top. We got colesevelam and bromocriptine that are FDA approved for diabetes. But when you sort this all by time, you get this curve right here. And so there literally has been exponential growth in the options for diabetes treatment. I'm sure you all are feeling this in your own practice, where there's just this explosion of options for treatment. And some people view this as that we're in a golden age, where decades of basic science advances have given us all these options now, and we have this variety of options, but it can be quite confusing for doctors and patients. We add on to that the fact that there's been also advances in the monitoring for diabetes, thinking about the old test tape that was used for just testing urine for glycosuria back in the 50s and 60s, all the way up to continuous glucose monitors now. What's the meaning of all this? Well, unfortunately, diabetes is now our country's most expensive medical condition. This amounts to approximately $330 billion per year, roughly speaking, $1,000 from every single man, woman, and child in the U.S. per year. Roughly 1 in every 7 healthcare dollars is spent in the care of diabetes. That's all healthcare dollars in the U.S. And roughly 1 in 4 healthcare dollars is rendered to the care of a person with diabetes. That is an enormous, enormous expense. So lest you think that I'm trying to bash people with diabetes and say that they're unworthy of treatment. No. This data is from the American Diabetes Association, basically trying to raise the alarm about where this is going, right? So if we think a little bit more about direct medical costs per patient, we're talking about, roughly speaking, $10,000 a year in direct medical costs for a patient with diabetes. That's a lot of money. And when we add in indirect costs, things like opportunity costs or the costs of losing work to travel to doctor's appointments and things, that's another $4,000 per year. So the way that I'd like to frame this talk is, how do we help our patients maximize the value that they get for all that expenditure? How do we optimize the value and find value in diabetes treatment? What are we getting in exchange for all of this outlay? So can we at least improve cardiovascular outcomes? What about that? So here I actually have a bad story to tell. You notice that on the timeline that some of these meds they fell off the timeline. And one of them was rosiglitazone that fell off the timeline after a meta-analysis showed that even though the med was lowering blood sugar, it was causing more heart attacks. It was causing more adverse cardiovascular outcomes. And when rosiglitazone went down, the FDA completely changed its game and required any new diabetes medication to prove cardiovascular safety using a meta-analysis of all of the trials that company has. And if that trial shows that it can't exclude an odds ratio a relative risk less than 1, that company had to do a post-marketing long-term safety trial to prove that there was cardiovascular safety. And it took several years, obviously, for that pipeline to get refilled. The first one to do so was the med empagliflozin. This is, I'm going to say the brand name, it's Jardiance. Empagliflozin was the first med to demonstrate cardiovascular safety in a post-marketing clinical trial. You can see curves, basically red being the med and gray being the placebo, for death from cardiovascular causes, all-cause mortality, or hospitalization for heart failure. So not only was the med not harmful, but the results showed a meaningful benefit. And so this med gained a special second FDA approval to prolong life expectancy in people with diabetes and heart disease together. It's not just approved for diabetes, it's gained that second FDA approval for this purpose. One of the other surprising findings that was completely counterintuitive when the med came to market was that there also seems to be protection from worsening diabetic kidney disease. So when the med came to market, we all expected that it would work as a diuretic and would cause dehydration and acute kidney injury. As it turns out, the opposite is true for most people. So it is possible to cause dehydration and kidney injury, but the majority of people see protection from worsening diabetic nephropathy. The downsides of this med, the med basically works by forcing the kidneys to drop sugar into the urine. It prevents the kidneys from resorbing glucose. And that obviously makes the med function as a diuretic. We've talked about that. Since microbes love to eat sugar, there is an increased risk of urinary infections, cystitis in women, and genital mycotic infections, yeast infections in both males and females. There's a long pipeline of these cardiovascular outcomes trials. These are the ones that the FDA mandated after rosiglitazone went down, and many of these have reported out now. And I'm just going to sort of summarize this. This is from the American Diabetes Association guidelines, that there are several meds now that have proven benefit for patients with diabetes and heart disease together. So prevention of heart attack, stroke, bypass, revascularization, hospitalization for unstable angina, et cetera. Empagliflozin we talked about, canagliflozin, Invokana, liraglutide, Victoza, and semaglutide, Ozempic. For patients with heart failure, with congestive heart failure, we have superior outcomes, low risk of cardiovascular death or hospitalization for heart failure. These are the entire class of those SGLT2 inhibitors, empagliflozin, canagliflozin, dapagliflozin. These are the meds that make you pee out sugar. There are also several meds that have now demonstrated protection from progressive kidney injury. These also are the same class of meds, the SGLT2 inhibitors, canagliflozin, empagliflozin, dapagliflozin, and then the injectable meds, liraglutide, semaglutide, and dulaglutide, which is Trulicity. So, other than that, is there any other value that we can deliver to patients? What other value can we find? Are there meds that have other benefits? Well, first of all, I need to say straight out that metformin is still the optimal monotherapy for diabetes for most people, despite what you see at the bottom of internet web pages. It remains recommended as first-line therapy by almost all of the major guideline writing committees, with a few exceptions that we're about to talk about. Metformin has multiple secondary benefits. Oh, I keep hitting the wrong button here. Stabilization in body weight or modest weight loss, not the kind that bariatric surgery is going to deliver. Improvement in certain lipid profile, a likely reduction in cardiovascular events from an observation seen in UKPDS, a likely mortality or survival benefit, and lower cancer incidence. The nature of these is unknown. How this happens is unknown. I got a few important points to get across about metformin. The first one is a warning to all you prescribers. Beware. Metformin extended release 1,000 milligram tabs will cost your patients thousands of dollars. Why is this? Well, first of all, I need to say that metformin has been generic for decades, and here in Richland, when I last looked on goodrx.com, the cost of 120 tabs of metformin here in Richland is about $5. That's for someone with no insurance paying cash. Unfortunately, there is only one brand of metformin 1,000 milligram extended release tabs, and that brand, Glumetza, was purchased in 2015 by an investor pharmaceutical company. Here in Richland, the price range for Glumetza is between $255 to $5,000 for 120 tabs. So I hate giving money to greedy people, so just beware. If you've got a person that wants 1,000 milligrams twice a day of metformin extended release, just write them for the 500 milligram tabs, please. A few other things. When I was in residency, we didn't prescribe metformin to people with moderate kidney disease for fear of lactic acidosis. That guidance is all different. The FDA has come out with revised guidance saying that metformin is safe and seems to extend life expectancy even in patients with moderate kidney disease. So for all patients taking metformin, we follow the GFR. If the GFR drops less than 60 and we're giving radio contrast, we hold it for the procedure. If the GFR drops less than 45, we don't start metformin, but we can continue it at lower dose. And if the GFR drops lower than 30, we stop metformin. A survival benefit, a life expectancy extension, is seen for patients taking metformin even at a GFR of 30. I mentioned that there were some exceptions to the monotherapy guidance statement, and here we see them from this year's American Diabetes Association guidelines. It used to be that metformin was the only game in town for single med treatment of type 2 diabetes, but that's different now. So if you've got a patient with type 2 diabetes and heart disease together, and they come into you with a new diagnosis of diabetes and their A1C is 7.5, let's say, metformin is not the only game in town. You could start an SGLT2 inhibitor that we were just talking about, empagliflozin, canagliflozin, or you could even consider a GLP-1 agonist as the single therapy. So we'll get into the details of all those meds in just a few minutes. But for patients with diabetes and heart disease, heart failure, or chronic kidney disease, metformin is no longer the only game in town. So, how do we pick the best med after metformin? What do we consider? What options do we weigh? The treatment is completely individualized to the values and needs of the patient. So we consider cost, we consider the efficacy of the med, we consider just the excess treatment burden, how much work will our patients need to do. We consider the side effects, the effects on weight, the risk of hypoglycemia, or whatever else. So this is kind of the meat of the talk, so bear with me for a few minutes because it's going to get a little wonky. Let's talk about basal insulin as a second-line diabetes treatment. So basal insulin is the one med that we know lowers blood sugar for everybody with diabetes. It can be titrated very accurately, but it has a very high risk of hypoglycemia. And the weight gain is typically 2 to 4 kilos per year on average. And weight gain has been seen in virtually every clinical trial of insulin that's ever been done, starting with that first kid back in the historical slides. Weight gain is just a feature of insulin therapy. In this slide here, I kind of summarize the cost of meds, the various brands that you see here. Insulin glargine at the top. Here in Richland, when I checked about a week ago, it's about $341 a box. A box has 1,500 units of insulin, and that's 50 units a day times 30 days. That's what a box of insulin gives a person. So if your patient needs 100 units of insulin per day, they're buying 2 boxes a month, and you multiply those numbers by 2. Okay? In the right column of the table, I've calculated something. This is my own calculation. This is what I call the metformin index. This is basically how many patients could you treat with metformin for the same price of treating one patient with that med. So that is to say, if your patient's buying a box of insulin, they're spending the same money that would treat 64 patients with metformin. The other meds, Levemir, has a, unfortunately, even greater cost in metformin index. Now, thankfully, we have biosimilar insulins. We have insulin Semglee, and we have Basaglar, and we now have a sort of pseudo-generic insulin glargine that doesn't really have a brand name. Luckily, in the state of Washington, is everyone aware of this, that there is a law called therapeutic interchange that requires pharmacies to automatically substitute the lowest cost equivalent insulin? Is anybody not aware of this law? So when I write a prescription for insulin glargine, I put a little note on there that says therapeutic interchange, Lantus, Semglee, Toujeo, Tresiba, according to lowest cost. And the pharmacies in Washington have to respect that. They have to give the patient the lowest cost equivalent insulin if there is one. And we don't have to play this telephone game of new prescription, new prior auth, more frustration. So who's the ideal patient for insulin? This is someone with a high A1C, someone who has maybe burned out diabetes or has failed multiple other meds, someone who doesn't mind gaining some weight, and someone who has a regular or predictable diet and exercise regimen because the hypoglycemia risk is so high. Let's talk about sulfonylureas. They're pretty good meds. They lower the A1C about 1 point to 1.5 points. These work by making the pancreas release more insulin. So just like insulin therapy, the risk of hypoglycemia is high and weight gain is common. Unfortunately, in long-term studies, these meds can burn out the pancreas. And there is a risk of progression to insulin requirement. On the good side, I suppose, they're generic. These meds, if you're here in Richland paying cash, at a pharmacy, you're going to pay about $8 for a month of glipizide. That's the same cost as treating 2 people with metformin. Unfortunately, glyburide and glimepiride are a bit more expensive, but still not too bad. So our ideal patient here, the patient that really should be thinking about sulfonylureas, is someone that needs to minimize the cost of medications and doesn't want to give injections. Someone who's lean and maybe could tolerate weight gain, I suppose. And again, someone who has a regular or predictable exercise and diet regimen. Let's talk about the GLP-1 agonists. These are the ones that you see on TV every time you turn on your TV. The advertising for these meds is so heavy. These are meds that stimulate the glucagon-like peptide 1 receptor, which has several anti-diabetic effects. The first to come to market was exenatide Byetta, liraglutide Victoza, dulaglutide Trulicity, and lixisenatide, which is Adlixin. These are now meds that are available as once per week sub-Q dosing. They actually do a pretty good job lowering A1C. In the clinical trials, the lowering is only about 1 point in A1C percent, but I think as we'll see, some of the newer data is much more encouraging. The side effects of these meds are really, every med in the class has the same side effects: nausea, vomiting, These meds slow down the emptying of the stomach. That's one way that they work. They prevent the stomach from emptying quite so rapidly. And if I were to eat a big, huge meal, if I were to eat a normal size meal, all that food's going to sit in my stomach for hours and hours, and I'm going to get this sort of bloated, overstuffed kind of after Thanksgiving dinner kind of feeling that many brains interpret as nausea. So when I'm starting one of these meds, I coach my patients to really limit those portion sizes, keep those portion sizes very small to minimize that potential nauseating effect. That also helps to get the biggest weight loss benefit from the med. Other side effects can include diarrhea and headache. This is really a class effect. All the meds in this class do this. There are rare side effects of pancreatitis. The most common pancreatitis is gallstone pancreatitis, but there are rare hemorrhagic pancreatitis cases that are seen. The risk of hypoglycemia is very modest with these meds. And the weight effect is substantial. So there is sustained weight loss seen in virtually every single one of these meds. And that is the primary, I think, selling point, if you will, of these meds. So here's my table again about costs here in Richland. The average retail cost of any one of these meds is going to be $800 or more. So for Victoza, at least last week here in Richland, you're going to pay $1,000 if you want a month's supply of Victoza. And with that same money, you could treat 200 patients with metformin. 200 patients. Some of the newer meds that your patients are seeing all the time on TV, semaglutide sub-Q, which is Ozempic, is $1,300 a month. And the oral version, Rybelsus, is about $900 a month. So our ideal patient here is someone who's obese and has good insurance. Someone who really wants to maximize the weight loss benefit while treating diabetes. This is my own editorial advice here, just sort of little pearls of wisdom, if you will, from someone who's prescribed these a lot. I would start low and go slow. Start at a low dose of the meds. Don't jack the dose up because that is going to maximize nausea and the patient's going to hate the med and hate you for prescribing it. I would focus on portion size reduction, on reducing the portion sizes of meals, and focus on a behavior called early meal termination. So that's when we push the plate away and back away from the table. That behavior of meal termination actually has a neuroendocrine basis. There's a receptor in the brainstem that receives the GLP-1 hormone and tells us that we're full. We just feasted. So patients can actually, if they kind of tune into this effect, they may notice that their appetite decreases very steeply during the meal, that they can end the meal earlier than usual, and we give them permission to not clean their plate, to leave their plate half full and just say, I'm done, I'm good. That's going to help them minimize the side effects of the med and maximize the weight loss benefit. So I would start low, go slow, only advance as the GI side effects allow, and focus on those behaviors of meal termination. So what about the DPP-4 inhibitors? So the DPP enzyme, this enzyme here, breaks down naturally occurring GLP-1 hormone. So if we inhibit the enzyme, we can get a little bit of this same effect. I think about these as sort of like Victoza light, or Ozempic light, if you will. These have similar anti-diabetes effects as the previous set of meds I just talked about, but they don't have the weight loss benefit. They just don't get enough of that hormone active to really give that weight loss benefit. So there are a few anti-diabetic effects, but not the weight loss. So here in Richland, unfortunately, you're going to pay a lot for these meds. I'm somewhat disappointed to see that, a month of Januvia here in Richland is $500. That's 100 patients with metformin. The med that's got the lowest market share is alogliptin or Nesina. It's only $100 a month. I have a feeling that's just more based on marketing and market share stuff. Our ideal patient for one of these meds desires the convenience of a once daily pill, maybe needs a med with a very low side effect profile. These meds have a very favorable side effect profile. They're overall very well tolerated. A person who wants to avoid weight gain but doesn't need to lose a great amount of weight. Someone who wants oral meds, and unfortunately someone who's willing to pay more or have very good insurance. Let's talk about a somewhat older med, pioglitazone. Pioglitazone is an insulin sensitizer. It works by making the body more sensitive to insulin, particularly our fat cells. This is a pretty modest med. It doesn't lower the A1C all that much. Its side effects include fluid retention and weight gain. Because of the fluid retention, it is not to be used in people with heart disease at all. Minimal risk of hypoglycemia, and it's a once daily pill. So as far as its profile, here in Richland it's going to cost about $15 a month. It's generic. So our ideal patient here is someone that does not have heart disease, who really needs to minimize the cost of meds, who wants a once daily pill, and is willing to tolerate some weight gain. There are anecdotal reports of certain populations of people that seem to do extremely well with pioglitazone. There are anecdotal reports of people of South Asian ancestry that struggle with insulin resistance out of proportion to weight. And an insulin sensitizer med could be especially useful for those people, but I have yet to see a clinical trial supporting that claim. Let's talk a little bit about acarbose. Acarbose is a med that works by blocking the digestion of carbs in the intestine. So if I eat a carb-containing meal and take an acarbose, it will block the digestion of those carbs and prevent me from spiking my blood sugar up. This prevents the rise in sugar that's seen after a meal. Unfortunately, the unabsorbed carbs are then fermented into gas by the bacteria in the intestine, and if I eat a big plate of carbs, I'm going to fart a lot. I have a patient of mine who was a bus driver for Metro in Seattle and was on acarbose. And on his break one day, he went into Burger King and ate a Whopper extra value meal with the big thing of French fries. And he said that an hour and a half later, he cleared out the front half of the bus. I have another patient of mine from Swim who, when I met him, was taking 5 injections of insulin a day. He was blowing $1,600 a month buying insulin. And he wanted to do a low-carb diet. He was really intrigued by the low-carb diet trends, but he was afraid to because he knew that the insulin would crash his sugars out. And so we started him on acarbose. We cut his insulin doses in half. He did his low-carb diet, and 6 months later, he was off all insulin. And he cried tears of joy because he was saving $1,600 a month and getting himself out of debt. So back in the early 90s, when acarbose came to market, you know, the quote-unquote diabetic diet was a relatively high, high carb, 180-gram carb per day, low-fat diet. And the med was poorly tolerated by patients. But the med has actually found a second life now for people that really are motivated to do a low-carb diet, for people that can sustain that. The acarbose can mop up the few remaining carbs that are inevitable in that diet, and so you'll have the minimal side effects. So let's go back to this figure here. Acarbose is generic. It's $17 a month, paying cash here in Richland. That's a metformin index of 3. Our ideal patient here wants to take pills over injectables, wants to stabilize weight or lose a bit of weight, and really is motivated and has a plan to limit carb intake. And that is just absolutely essential. So my little pearls of wisdom here, the med needs to be taken with the first bite of the meal. It needs to beat the food down to the digestive enzymes. Because if the food gets there first, the med's ineffective. So the patient may need to carry the med around with them in their pocket so that they have it at the first bite of the meal. Obviously, you need to minimize digestible sugars, so starches. Starch is a polymer of glucose. A single molecule of starch will digest down into 300 to 600 molecules of glucose. So they need to minimize that. They also need to avoid monosaccharide syrup. So high fructose corn syrup is just straight up glucose. It needs no digestion. It is absorbed right away. Glucose syrup will laugh at the acarbose on its way into that person's bloodstream. Okay, so they need to minimize all that stuff. Let's talk about the SGLT2 inhibitors. These are a relatively newer class of meds that, again, make a person pee out sugar. They make the kidney release sugar into the urine. Pretty good A1C reduction. We've talked about the major potential side effects here, UTIs and yeast infections. And we've talked a little bit about the long-term benefits. There's a minimal risk of low blood sugar. These meds cause a little bit of weight loss, 2 to 4% per year. Here in Richland, now granted, I don't mean to trash these meds. I've been saying in earlier slides, these meds have favorable long-term effects on the heart and kidneys, and these are pretty good meds. Here in Richland, though, you're paying about $600 a month for them. It will be a very good day in our country when these meds go generic. And let me just editorialize and say, I can't wait for Medicare to start negotiating drug prices with these drug companies. So they're good meds, they're just expensive. You could treat 100 patients with metformin for the same price of treating one patient with Jardiance. So our ideal patient here desires a once daily pill, desires modest weight loss, has heart disease or chronic kidney disease, who wants oral meds over injectables, and unfortunately someone who has good insurance or is willing to pay more. As promised, we're going to talk a little bit about the newest med to market. This is tirzepatide or Mounjaro. Wegovy is the other med, the other brand name when the med is for weight loss. It is similar to the GLP-1 agonists, but it also tickles the GIP hormone receptor. The practical effects of this in clinic aren't big. The practical effects are that it is a once weekly med, injectable, just like its competitors, Ozempic or Trulicity. In its clinical trial that was published in New England Journal of Medicine in April, 2,500 patients with type 2 diabetes, everyone on metformin already, everyone with an A1C over 8, randomized to the med. They actually didn't have, this is not a placebo-controlled trial. Their placebo was Ozempic. They have an active comparator here. That's the gray line that you see here on this curve. So if they give that patient Ozempic, there's pretty good A1C lowering there. The average A1C is under 6.5. There is an improved response with each dose of the tirzepatide. So the max dose of tirzepatide, they got the A1C down to 5.8%. This is a phenomenon that we see across the entire class of medications. There's this sort of diminishing returns phenomenon. The 5 milligram dose does an awesome job. The 10 milligram dose is a little bit better, and the top dose is kind of no different. So that's why I sort of said start low and go slow with the dose advancement with all of these meds, because there's this diminishing returns phenomenon here. The other major benefit of this med is weight loss. So again, we're not putting the bariatric surgeons out of business yet, but there is superior weight loss with this med compared to, again, this is not a placebo. This is Ozempic. This is an active comparator. In this trial, this is a diabetes trial. This is not a weight loss trial. The patients in this trial were not all given intensive lifestyle counseling like they are in weight loss trials. This is just take the med and good luck. In that trial, 80% of people got at least 5% of their weight off. Over half of people got at least 10% of their weight off, and a third of people got 15% weight loss. Those are pretty nice numbers, And again, this is not the excess body weight lost. This is total body weight. This is total body weight loss. So these are good numbers. When we think about safety and tolerability, just like with all of the GLP-1 agonists, the more you give, the bigger the side effects. So just like all of the GLP-1 agonists, lots of nausea, vomiting, and diarrhea, and those rates increase with the more dose that you give. In this trial, which was conducted during the COVID pandemic, there were more deaths in the group that got this med, tirzepatide. There were more deaths, but they were adjudicated to be COVID pneumonias. So I don't know. I don't know if this is a thing, if this is actually a med effect, or if this is just an artifact of treating patients during the COVID pandemic. I don't know. What I do know is that there were more dropouts for adverse drug reactions in the group that got tirzepatide compared to Ozempic. So roughly double the number of people dropped out for adverse effects at the top dose of the med. And again, those side effects are mostly nausea, vomiting, diarrhea, headache. So let's put this newest med on our summary slide here. Here in Richland, you can get a month of Mounjaro, tirzepatide, for about $980. And for that same amount of money, you can treat 183 patients with metformin. So our ideal patient here is someone who is obese and wants to maximize the weight loss benefit, who needs to avoid hypoglycemia, someone who has suitable insurance or willing to pay more. And frankly, let's be honest, someone who is willing to recur somewhat of a higher risk of the unknown. We just have less clinical experience with this med. This is my advice. This is my editorial advice here. Start low, escalate only slowly. The 5 milligram dose of tirzepatide did almost as good as the max dose. The max dose gave you just a little bit more benefit, but more side effects. And again, just like the GLP-1 agonists, focus on smaller portion sizes and early meal termination. That helps to maximize the benefit of the med. Let's talk a little bit in the few minutes that I have about continuous glucose monitors, because I'm sure that patients have asked you about these. And again, we're looking for value. What value are we adding to that patient's care? So I think by now you all know what I'm talking about. These are small devices that are attached to the arm or the abdomen that have a little platinum electrode that goes through the skin, and that platinum electrode is coated with glucose oxidase, so that electrode functions like the inside of a test strip and converts interstitial glucose into an electrical signal in nanoamps. And that can be outputted to a smartphone or some external reader device. Some of these will read continuously to the phone and drop a new dot of data in every 5 minutes. Others need to be scanned to give a reading. But it basically gives a pseudo-continuous output of sugar. Basically a new dot of data every 5 minutes. So let's get real here. Let's talk about the pros and cons of these. There are certain situations in which this technology has clear advantages. So obvious advantages. People that have hypoglycemia unawareness. They have low blood sugars and don't have symptoms. People that have nocturnal hypoglycemia and need an alarm to wake them up. People who have severe hypoglycemia events requiring rescue by EMS or family members or bystanders. These are folks that having a low blood sugar alarm would be great. There are also situations in which people have extreme insulin sensitivity, people that are very brittle, or people for whom if they dose insulin off by just a unit, they can go low. I have a population of athletes in my practice as well, including some very high-functioning professional athletes for whom this is absolutely essential. Finally, people that are using this data to drive an insulin pump. Most of these things here, if you're coming across these patients, specialist referral is recommended because more than just monitoring the sugar, we need to have a plan to prevent these events or do something about it, and that's where the complexity often arises. Unfortunately, the marketing of CGM does not really focus on a lot of these things. The marketing of CGM devices to patients focuses on convenience, the reduced pain of testing and the reduced fear of hypoglycemia. These are the selling points, if you will, that companies are using in their marketing of this technology. And there is very high level adoption of it, primarily for those reasons. So here I also want to pause for a second and say that hopefully you'll finish this talk concluding that I'm not here to sell you anything. I'm not here to convince you to buy anything. I don't carry any water for companies that make meds or devices. But there are guidelines out there about the use of CGM, and unfortunately, those guideline writing committees all had a voting majority of committee members that were either employees of the companies or on the Speakers Bureau. And those guidelines don't actually have any appropriateness standards in them at all. They basically just list people for whom the CGM is appropriate, and it's basically everyone. There are also papers out there discussing the cost effectiveness of CGM, and every single one of those papers is written by an employee of one of the companies that makes the technology. So I'm a bit skeptical. This is my own cost analysis here. This is data from Richland as well. And here on the left we have this table of how many tests per day our patient is doing and where they're getting their test strips. Are they buying a generic store brand from a big box nationwide retailer? Are they going online to a big online retailer and buying test strips for 45 cents a piece? Or are they walking into a retail pharmacy and paying cash for a name brand test strip? If they're doing that, they're paying about $1.12 a test strip. And if they're testing 6 times a day doing that, that's about $2,400 a year. And at that price, the Freestyle Libre Flash is cost effective. But for everybody else, it's not. So if you're going online and buying test strips, you could be testing 8 times a day, and your annual cost is still half that of a Freestyle Libre Flash. If you want a Dexcom G6, that's $6,000 a year, and I can't even make a table that gets to $6,000 here. It's just a lot. So here again, we have to make a value judgment. What is the value that this device is adding to the patient? Now, the convenience factor, the reduced fear of hypoglycemia, the reduced pain of testing, that may have value to the patient. But I think that we need to be upfront and say, this is what that value is going to cost you. And that we should just not, I don't mean to make us into the bad guy, but we just need to provide the information so that the patient can make their value judgment. Right? So I've got maybe a minute or two. Let's think about a hypothetical patient. A 64-year-old patient with diabetes returns for follow-up. Her glucose average in the morning is 165, and she has a couple of hypoglycemia events per week, including an overnight event. She has hypertension and hyperlipidemia. She has obesity with a BMI of 33, and she has sleep apnea. Her meds are metformin at max dose, Lantus, 25 units every bedtime, atorvastatin and lisinopril. And her labs show an A1C of 8.5%, an elevated urine microalbumin, normal creatinine, and a little bit of an ALT rise on liver function tests. So hopefully this is similar to many patients that you have seen in the last year. This should not be some zebra. So this is my question. What should we do? What is our recommendation? Should we prescribe a Freestyle Libre 2 continuous glucose monitor? Should we reduce the Lantus and add Jardiance? Should we change the Lantus to Ozempic? Or should we prescribe a very low-carb diet and change the Lantus to acarbose? I might add E here, following the last talk. Should we send this person to bariatric surgery? BMI of 33. There's no right or wrong answer here. There is none. The treatment is individualized. The treatment is, the ideal treatment depends on the patient's values and preferences, how that person weighs a weight loss benefit versus cost versus cardiovascular benefit versus lifestyle choices or lifestyle goals that this patient has. So hopefully I've given you a little bit of a sense of the range of choices that are out there and the pros and cons. And I appreciate your time.